Good morning, everyone. Thank you for being here. Welcome to the seminar. We have Dr. Jon Snyder today. He is the Director of Transplant Epidemiology in the Chronic Disease Research Group at Hennepin Healthcare Research Institute. He also has other positions that are listed up on there, so I won't go through all of them. He's going to be talking about how statistics and just generally a systems engineering approach plays a role in the transplant system in the country. Please join me in welcoming the speaker.
Well, thank you. Good morning. Thanks for braving the winter morning to be here. Thank you, Professor Singh, for the invitation to be with you. As she mentioned, my affiliations are on the screen, and I was just telling her that this systems engineering probably would have been where I landed had I known about it when I was going through school. But I'll give you a little bit of my background, and then we'll jump into transplant. Before we get into the work, though, anybody here have any direct experience with transplantation in your family or friends? Have had an organ transplant? I always like to ask that question because that's something that kind of hits close to home. It's nice to have that connection, but no worries if you haven't. My goal with all of this is to interest you in how systems engineering can play a role in this field. I think systems engineers, even though I am not one, have a key role to play, and I'm hoping to convince you of that by the end of this. How many are master's students? Okay, any Ph.D. students? Okay, a few, so excellent. So if nothing else, at the end of this, hopefully you have a sense of how your work can really impact patients for the better. I think it's an exciting field. Transplantation is complex. And I think we need brains like are in this room to make it better. And I know you've worked in it for a long time, so we'll step through. I do want to welcome my daughter in the background. I'm going to embarrass her and call her out. She's a master's student next door in landscape architecture and urban planning, so I invited her. So it's nice to have her here. So, all right, let's see. There we go. All right, so about me. My undergrad was mathematics education, so I always felt like I wanted to end up in the medical field, but I knew I didn't want to be a physician. And I thought, how can we use math to actually make healthcare better? Which is why I think I probably would have landed in this field had I known about it. I ended up in biostatistics, and I think there's always a close tie between this department here and biostatistics in terms of the types of things you're learning. Now we see more data science and that type of application. But back then, data science wasn't really a field yet, I guess, and so biostatistics is where I landed. Then I went over to the epidemiology and did the doctorate there in epidemiology, all here from the University of Minnesota. And she mentioned that where I've landed, I've been at Hennepin Healthcare Research, which is the research institute across the river at Hennepin County Medical Center. It's a nonprofit affiliate research institute of the University of Minnesota Medical School. So, although it's across the river, we have ties here to the university as well. I went the wrong way. Here we go. All right. So our work is in specifically solid organ transplant. And I like to make that distinction because there are other types of transplant. But what we're talking about, the work that I've been involved in, involves heart, lung, liver, pancreas, kidney, and intestine, and this thing called VCA. Has anybody ever heard of this VCA type of transplant? I don't have an arrow here. But anybody have any idea what that might be? Take a guess. Skin? Yes. Skin. They're doing hand transplants, face transplants. If you've seen these, some of these have been on the news. And there was a cover article on National Geographic magazine maybe 10 years ago about the emerging field of face transplantation. For the purposes of our country's transplant system, that is considered an organ transplant, even though it's technically not an organ, right? But it falls under the purview of the governance in our country about organ transplantation. So when we talk about VCA, there's a couple things we do. You mentioned skin. Scalp transplants, that can be done. I won't get into detail about these, but I just think it's interesting. Face, I've mentioned, where they can transplant the whole structure of a face from one person onto another if somebody's had a devastating injury to their face. That can be done. abdominal wall and hand transplants can be done. A lot of these done with soldiers that have had a hand traumatically amputated. That can be done. And then there's some reproductive transplants that are happening. Uterine transplants are happening, and penile transplants can happen as well. The uterus transplant is an interesting one because it's the only one of all these that is meant to be temporary. It's transplanted for a purpose so that somebody can give birth to a child. Once that is hopefully successfully done, they would then remove the uterus and not leave it in the person, because then that person has to take immunosuppressive medications for the rest of their life. Okay, so the only one that's meant to be temporary.
Okay, so I just have two questions. One, what does VCA stand for?
Oh, I'm sorry. Yeah, vascularized composite allograft is what it stands for. And it just means that it's vascularized tissue in a composite of lots of different kinds. So when you think of face, they're transplanting the skeletal structure as well as all of the tissue and the muscle and all of that, and the blood vessels. So it's a vascularized composite graft.
Okay, the other question is, does bone marrow not count as solid organ? Or?
That's right. That's an astute question. Yeah. So when I mentioned that I'm talking solid organ transplant, these are the things that covers, and these are the space that our group is involved in. Stem cell transplantation or bone marrow transplantation is also a field of transplant. We're not involved in that. And there is, however, the National Marrow Donor Program here in Minneapolis that runs that for the entire country. So our team at Hennepin runs the Scientific Registry of Transplant Recipients, which is the federal registry in the United States for all transplantation, solid organ. And then just so happens, by coincidence, that the stem cell registry is here in Minneapolis as well. So this is a hotbed of transplantation for the country. All right, on to the interesting stuff. So I'd just like to set the stage by the current wait list, how many people in this country are waiting. And there's right now, I pulled this on November 6th. So on November 6th, there were 104,610 people waiting for organs. And this is where I want you to start thinking about systems engineering. Right? How do we meet that need? Okay, that's for kidney. Let's see, here is kidneys. There's 90,000 people plus waiting for kidneys in the country as of 2 weeks ago. That's by far the biggest. So the biggest need in this country is kidney transplantation. Liver is the next, and you can see how that's sort of dwarfed by kidney. Okay? And these are point counts on the list, right? You think of how many, if I ask the question, how many people are on the list on that day? That's how many people, okay? So that's not how many people in the year were on the list on that day. Okay. Heart, you just for context, you can see how many people are waiting for each of these. So let's compare that to how many transplants are done. So now the yellow bars are how many transplants were done last year. So the maroon bars are how many people were on the list 2 weeks ago. The yellow is how many of these were done. So you can immediately see the gap, right? So kidney, 28,144 were done in 2023, and now we've got almost 100,000 people waiting. So you can see the gap. Some of the others, you can see that for liver, heart, and lung, we're actually transplanting more people than are on the list on any given day. Those lists tend to turn over more quickly, so there isn't this built-up demand there. But the interesting thing, people say, well, we don't have a problem then with those other organ types. Not really true, because these bars now in the red are people that die or are removed from the list before they get a transplant. Okay, so you can see how many. You can't see some of the reds as they get smaller, but you can see the numbers there. So 8,000, almost 8,500 people last year died or were removed from the kidney list because they became too sick to survive a transplant. Okay, so that is kind of the supply-demand sort of thing that we're dealing with here. Okay, this is the demand side. So I translate that into real numbers. One of the things we do is we have a press team that tries to convey these numbers to the public, right? Okay, and this is kind of how we like to put it. So 13 people die each day waiting for an organ transplant in this country. Okay. I think you kind of distill it down into numbers that people can get their head around. An additional 16 per day are removed from the list because the way I interpret it is we didn't find them an organ in time. We had to pull them off the list because they've now become too sick. Their physicians don't feel they would survive the surgery. Okay. And so if you add those up, we got 29 people a day that I think the system is failing to meet their need. Right? The physicians thought these people could benefit from transplant, but almost 30 a day are being removed because we couldn't meet that demand for these patients. As I was thinking about this talk, I was thinking about Huntington Bank Stadium right down the street, and I thought to myself, how many people does that seat? It seats 50,805 people. Right? So if we sold out 2 games, that would seat 101,610, and that is not even how many people are on the wait list. So I like to think like I'm a numbers guy, but I like to visualize something. Right? So if we sold out Huntington Bank Stadium twice, that would be the number of people that need transplants in this country. So it really thinks about it. So how do we go about meeting that need? This is where systems engineering really starts to play a role. And I hope to convince you of that. We'll see how I do. So how do we get people those organs? Is it random? I was envisioning Goldie with his t-shirt gun, you know, just shooting randomly into the crowd. No, that's not how this happens. We don't randomly draw numbers. You could do that, right? You have everybody in the pool, and you blindly reach into the bag, and you pull out a number, and oh, kidney patient 5006, you're the lucky number, you get this kidney. Doesn't happen that way, okay? That's not what happens. We're not randomly tossing them out. We're not auctioning them off. People have proposed this, though. How could we solve this problem? We could auction them in some way, whether that's the hospital would bid on them, or patients themselves would bid on them, perhaps pay for them. I mean, all of this has been talked about and proposed. It's one way you could do it. It's not what we do, I think, thankfully. So we have a waiting list, right? And people think of this, they think of people just get in line and wait for organs. And it's a little bit more nuanced than that. And I'll show you some of what I mean by that as we go along. But this is more toward the truth. There's a national wait list. We have some way to figure out all over the country what order people are in. And then we start offering organs to them. Okay. The reason I say it's nuanced, just think about one of the things that I'll talk a lot about today is geography. The problem of geography. Okay. If a donor hospital has a patient in the northeast corner of Maine, and whatever way we want to sort this list, the first person that pops up happens to be in San Diego, California, opposite corners of the country, or even think Hawaii. There's a transplant program in Honolulu. It's probably not the best idea to try to fly that person's organs to Hawaii, right? There's a give and take here. And so the order of the list can shift around depending on characteristics of the donor that's being offered. And so that's why I say it's nuanced. It's not you get in line and you wait and you get the next offer. It depends on where the donor is. It depends on characteristics of the donor. In lung transplantation, for example, lungs are interesting because they have to fit in your chest cavity. And so there's a size matching process that has to happen. You can't take anybody's lungs and put them in anybody else. You have to look at the size of their chest cavity. And so the list ordering for lung is going to move around depending on who can actually fit those lungs in them. Okay, so that's an important part. So it's nuanced by organ, and it's nuanced by donor that's being offered. Okay, and this is the major problem. How do we do that in a smart way? How do we sort the list? How do we think about efficiency? How do we think about geography? Lots to think about in how we order this list. But to the lay person, I would say they think, I'm on the kidney list, I'm in line, right? I'm waiting. I'm patiently waiting in line. And it's a little more nuanced than that. But people in our field love nuance, right? We're here to solve that problem. Right? All right, so I'm going to give you a brief history of time of the transplant system in this country to set the stage for how we think about systems engineering this problem. Okay. All right. So initially, when the field of transplant started, and it's not that old of a field. This field in medicine is, in the 50s and 60s, where some of these things were starting to be done. So we're, maybe 70 years into this. But initially, this was happening. There would be donor hospitals that had somebody that maybe is brain dead in their hospital, and they know. Let's say this is over across the river at Hennepin County Medical Center. And they know that the transplant team here at Minnesota has a patient that could use those kidneys, for example. And so the hospital literally knew these people and would just call them on the phone and say, hey, I think I have a patient, we've got some kidneys, I think you have a patient that could match them, let's do this. So it was like literally phone calls for solving this problem. There was no national list, okay? And then these organizations were created called organ procurement organizations, or OPOs. I'm going to talk a lot about those. And they were organized by the federal government to serve a geographic area. And I'll show you what this looks like. And then they began to do a matching process because they're starting to become lists at different hospitals. And so people started to think about, well, if I'm HCMC, well, Mayo in Rochester has patients. Should I call them or should I call Minnesota? How do I make that decision? So it kind of was turfed over to these OPOs to figure that out, okay? Figure out a way to do this. And this is all before the federal government instituted a national policy for how this is done, okay? So that's where we're heading with this. So there are now 55 of those organ procurement organizations in the country, and these are the service areas that they serve. Okay, so they sometimes follow state lines, not always. They mostly follow county boundaries, but not always. Okay, and so you can see some weirdness on this map. So there are currently 55 of those in the United States. And so what that means is if a donor pops up in Arizona, anywhere, at any hospital that has an ICU where they can have donors, that Arizona organ procurement organization would handle that case, and then they're in charge of allocating the organs out following whatever the policy is. Okay, so let's talk about our service area. So this is the service area. Have you heard of LifeSource? This is the organization here in Minneapolis that is the organ procurement organization for that service area. So they manage, they're just across the river up here, they manage Minnesota, North Dakota, South Dakota.
Minus one county of Minnesota.
Minus this county, which is managed by Madison, okay? And we get a few in Wisconsin up by Duluth and in what's considered the metro area here, right? So what that means is if there's a donor that dies in a hospital and is on a ventilator at any hospital in that service area, LifeSource gets a phone call. There's a mandatory reporting. They have to call the organ procurement organization. They get involved, and if there's really donor potential there, they will manage the process and offer those out. But remember the rule that I showed you on the prior slide. Remember initially it was phone calls to hospitals. Then it became that this organization would try to sort this out, okay? And these blue dots represent the transplant hospitals in their service area. That's what those are. So it's not every donor hospital, but it's all the hospitals that do transplants. And so down in Sioux Falls there are 2, that's why there's 2. Here in the Twin Cities there are 4. There's one in Fargo, one in Bismarck. This is Mayo, Rochester. And then these other dots down here are not inside their blue area. They're not in their service area. So for the longest time, the way this was proceeding was LifeSource would call the blue dots, because they're technically the transplant hospitals that are in their service area, okay? And hopefully you can immediately start to ask the question, is that the smartest way to do this? Is that the fairest way to do this? Let's assume that there's a donor that pops up at Mayo. So most of the traumas in that area of our state maybe are flown to Mayo by helicopter, and if a patient dies there, LifeSource is gonna offer it out in some order here. But they might, under those old systems, they might have called Bismarck for those kidneys before they thought about calling Des Moines, even though these are arguably much closer and easier to get to, okay, than shipping those kidneys to Bismarck. But that's the way it was done. And people start to ask questions, and I'll show you some of those questions. Is that the smartest way to do it? So in 1984, there was a law passed in this country called the National Organ Transplant Act, and that established the authority for the federal government to essentially assert that there needs to be one national system for this. There needs to be centralized management of this process, and we need to make it as fair and equitable as we can. So I highlight a few things here. Now, the evolution of this is really important from a systems engineering perspective when it comes to geography, okay? So look at the bolded line up in that top one. In 1984, they said that they set up this organ procurement and transplant network, okay? That's what they called the network. It's still called that today. And it will assist the organ procurement organizations in the distribution of organs which cannot be placed within their service area. So originally when the law was first conceived, they said if they can't place it in that blue zone, then the OPTN will get involved and help them place it outside the blue zone. So it was still blue zone first, and then everywhere else in some order, okay? In 1988, there began some revisions to this thinking, okay? And I think people glance over this, but it's super important. They amended the law in 1988, and look what they changed that bolded sentence to this. Just assist organ procurement organizations in the distribution of organs. They took out that cannot be placed within their blue zone. Right? So they took that out. And then they went even further 2 years later. They changed it again, and they said they're going to assist organ procurement organizations in the nationwide distribution of organs equitably among transplant centers. So way back in 1990, at least the policymakers decided that this is there should be a nationwide system for this. We shouldn't be dealing with blue zones, okay? That's not fair, and I'll show you some examples of really why that is. So it wasn't until 8 years later, though, that they called for the creation of organ allocation policy based on medical criteria, not geography. So we need to figure out a way to get rid of the blue zones. Why it took 8 years, I'm not sure. But 8 years later, and then they issued what they called the final rule, which was supposed to go into effect in 1998. Okay, so you can see how new this field is, right? This is very new thinking. And I'm just going to show you a few things of what that said. Let me back up to this one. So this was the press release that came out. And you can see the date at the top, March of 1998. They issued this rule calling for organ allocation based upon medical criteria, not geography. So this is how you sort that list. Right? How do you sort who's on the list and how you offer the organs. And again, down here, it calls on this organ procurement and transplantation network to develop revised organ allocation policies that will reduce current geographic disparities in the amount of time patients wait for an organ, and calls on the OPTN to develop uniform criteria for listing patients. It goes on to say some important things. This is from their comments associated with the rule, and I think this is the important part. We want to assure that patients with the greatest medical need receive the organs no matter where they live. Okay? No matter where they are in the country, if they have the greatest need, they should get the organs. Okay? But HHS, that's Health and Human Services, who oversees this, this will assure that organs are allocated on the basis of medical need and that availability of organs will not be impeded by arbitrary geographic boundaries, okay? Arbitrary lines. The blue zones, they're still calling for these to be removed. And this is, what, 10 years now after they first tried doing this. Things take time. But they knew this was the smart and better way to do it, right? Okay, so in 1998, there was a hubbub about this when it was released. And people complained. They thought that this was going to be unfair to transplant programs, that they're going to take their organs and send them to other places, okay? Because anytime you're going to redistribute things, there are winners and losers. And the people that were going to be losers figured it out quickly, that they were currently in a surplus area, and so this law was threatening to them. So they complained. And in 1998, shortly after, they put a pause on implementation, and they asked the Institute of Medicine to weigh in. Is this the best thing to do? And so they did that in July of 1999, and I'll back up here. They issued a press release that said organs should not be allocated based on should be allocated based on medical need across wider geographic areas. Okay, they didn't say no geographic areas; they said wider geographic areas. Okay. Let's see, I don't want to hit this one here. So assure that organs are allocated on the basis of medical need and the availability of organs will not be impeded by arbitrary geographic lines. And then this press release came out, and figure out which way is it going. Going backwards.
There we go.
Here we go. All right. So they issued an improved rule in 1999. Okay, improved. Okay, and this is the rule that still basically exists today. Okay, the board of directors established under paragraph 121.3 that organs allocation should be equitable. Okay, and follow these 5 criteria. Shall be based on sound medical judgment, seek to achieve the best use of donated organs, preserve the ability of a transplant center to decline. That one's fairly easy. Specific to each organ type, and designed to avoid wasting organs. You're going to start to think systems engineer now. Okay. How do we do that stuff? It went on to set some allocation goals for the system. How do we know that the system's working well? And it set a number of things. This first one is about that the priority ranking for a patient on the list should be about how medically high their need is, okay? Unless there's some other therapy that can keep them alive. Kidney, for example, has dialysis. So if there's an alternative therapy that can keep people alive, they're a little more lenient on how this rule is applied. But basically they're saying, first off, we should be getting these organs to the sickest people. And this one's the key here. Distributing organs across as broad a geographic area as feasible under paragraphs A, 1 through 5 of this section, and in the order of decreasing urgency for patients. And this might begin to look like, I'll put the key pieces together here. So we want to distribute across a broad area as feasible under those 1 through 5 constraints. Okay? That's the goal. That's what federal policy says we should be doing. And so reasons for restricting broader geographic sharing are boiled down to those 5 points. What I mean by the broadest sharing would be if that donor popped up in Maine and the highest acuity patient was in Honolulu, if you didn't take 1 through 5 into account here, you would ship it to Honolulu. You'd do that, no matter the cost or the damage to the organ or whatever it takes to fly it that far. But these other things are allowed to factor in, okay, by law. You can factor these things in. All right, does this begin to look like a linear programming optimization problem? How many people have had that class already? Many in this room, okay. That's exactly what this becomes, okay. So the objective is to distribute organs as broadly as possible and in order of decreasing medical urgency subject to these constraints. Okay. So you need to define mathematically how you're going to define each of those constraints. How would you measure those things? And you need to define mathematically how you create your objective function. And then you can optimize that. You can run that through your systems and come up with a policy that best optimizes that system. So I think that's pretty fascinating. Right? This is where the systems engineering begins to play a role, because you have an objective, but you have constraints. And how do we actually evaluate a policy around those constraints? Can we actually say, is this a good policy or is this a bad policy? Okay. All right, so I've talked a lot about how this was done historically, but it was a little more complex than what I showed you. And it started what we called local, and that was the donor service area. So you've already seen that map. So this used to be done this way. I'm going to pick on Dallas. Texas is the strangest of states. Anyone from Texas? You lived there for quite some time. So there are 3 organ procurement organizations in the state of Texas, identified as 3 colors, the yellow, the blue, and the brown. And when this, it's quite funny, right? Like, Texas, to me, is the perfect example of why this type of allocation is nonsense, okay? If a donor pops up in Dallas, okay, which is in the bluish purple here, and the law at the time was local first. So they're going to offer to any transplant program in the purple area, which might include El Paso, and it includes the Houston area down in here. And likewise, the Houston area includes Fort Worth. Okay, so if a donor pops up in Houston, they're going to offer it to Fort Worth before they would offer it to Dallas under this law. And Dallas is going to offer it to El Paso before they would be willing to drive it 5 miles to the program in Fort Worth. Okay, this is stupid. This is nonsense. Right? But nobody seemed to care about this. This is the way it was done for 20 years, right? Really, that's what was happening. And things like that, you can find other areas of the country where this happens. Right? This is accidents of geography. makes no sense. So they would look within their service area first. If they couldn't find anybody, there were things called regions, and they were broader areas, and they looked like this. And they were groupings of these organ procurement organizations into broader state-level categories, and there were 11 of them, and there still are today. Okay, so if they couldn't find somebody in Texas that wants it, then they're going to go to their region, which now includes Oklahoma. And if nobody in Oklahoma wants it, then they would go to what's national. Okay, so that's the order they would sort the list. They would go, I'm going to look in Texas. If nobody wants it, I'm going to call Oklahoma. If nobody wants it, then I'm going to go to the national list. Okay, this is what was happening for many, many years. And people started to notice that this doesn't work very well. Right? This is a map of essentially how sick liver patients are at the time they get their transplant. And liver patients' sickness is scored by something we call a MELD score. It's the model for end-stage liver disease, and that score has been updated many times throughout the years. But the green areas have the lowest risk, and the areas in the purple, patients that are getting liver transplants are much sicker in the purple areas than they are in the green. And this was what it looked like under that system. And this is, remember, the law says that we should be equitable as best we can while preserving those constraints. And so this is what we got. Patients in Arizona were being transplanted much later than patients in, say, Arkansas or this area of the country down here. Do you remember Steve Jobs, the old CEO of Apple? He got a liver transplant. So he was in the purple, a really high demand, low access area. And does anybody know where Steve Jobs got his transplant when he got it?
It was Tennessee.
Tennessee, yeah, Memphis. So he was down here in this area here, which is one of the lowest. They had the better access to livers. Okay, so people cried foul. It was on the news. Steve Jobs jumped the list. He didn't do anything against policy. Anybody in the country can list wherever they want. Maybe he had the resources to do it and to fly there when the liver call came. Okay, so people started to complain at this time, like, why does Steve Jobs have to fly to Memphis? He could stay where he is. Well, because he knew he'd have to get much sicker if he stayed in San Francisco. So what happened? There were lawsuits. People started to become aware. It surprised me that it took 20 years, but people became aware of this problem. And here's one in 2018. So this is not even 10 years ago. Okay, the firm Boise Schiller Flexner filed a lawsuit against the government on behalf of 6 patients in New York, California, and Massachusetts. And it called for the OPTN, this Organ Procurement Transplant Network, within 6 months to issue a new liver allocation policy that doesn't include these arbitrary boundaries. Okay? So it takes lawsuits for this to finally start to change. Okay? And those patients, the one in New York, by the way, this patient in a hospital bed in New York City, right on the Hudson River. Okay? Looking out her window of her hospital room is another transplant hospital across the river in New Jersey. Okay? And she started to ask questions. She said, so if a donor that could serve me in New York City dies at that hospital right across the street, and I could use that liver, because I'm not in their service area, I'm not in their blue zone, that service area is going to call down to the Philadelphia area before they drive it across the bridge and give it to me. And that was exactly right. And she said, that's not right. So she got the law involved, and they filed a suit, and it worked. Okay. So I'm actually thankful for patients like this that really take it into their own hands to try to make change, right? So that's the key part here. We got to get rid of these arbitrary areas and not do it this way. Summer Gentry is a colleague of ours. Anybody know her name? She was a mathematician at the Naval Academy, Ph.D. in your field. She's operations research. She does a lot of work with us. They published this paper back in Interfaces, which is an OR journal. Gerrymandering for Justice, Redistricting the U.S. Liver Allocation System. I highly recommend this paper if you're interested in this topic. And these are images right out of her paper. Okay? She basically turned this into a linear optimization problem. Okay? and basically said, she took it from a fairly narrow perspective and said, let's try to just design better regions of the country to distribute things and see if we can make them more fair. So she came up with this objective function to minimize this. She said the redistricting problem minimizes to the sum of absolute differences between the ideal number of donors in an area and the demand in the area. Okay, so she's trying to sort that out and create new regions of the country to do this. And then she knew there were these constraints, and so these are the constraints. And I'm not going to define the variables for you, but I'm sure I'll give you 30 seconds so you can read through that, and you'll know exactly what those mean, right? No, I'm kidding. I have to stare at these every time. So what do they mean? So this first constraint is that each donor service area can only be in one district. She started from the blue zones and said, can I just organize the blue zones into districts that gets better results? And so she said, well, each one can only be in one district. Ensure that the DSA is always assigned to the district for which it is the center. She had this idea of a DSA being the center and then other DSAs being attached to it. All right. There's always N districts, and this was something she could change. She could say, I want 4 districts, I want 6 districts, I want 8 districts. She can change N in this optimization problem. This sets the upper bound on what she called the volume-weighted travel time within a district. So she's trying to minimize within any given district that this optimization problem would find, minimize the maximum travel or some other definition of travel time within that district. So try to keep it as compact as you can, right? This one sets a minimum number of transplant programs within each district. She didn't want the system to create a district that only had one program in it. So she actually put in a constraint that there has to be at least, say, 3 transplant programs in a district, so we have some competition. All of these could be changed, right? You can mess with this problem and do it however you want, but then this final one, each DSA is assigned to the district whose center is nearest to it. All right, so that's how she created the objective function and the constraint problems, constraint functions. And then she published in her paper, if you did this and you wanted 4 districts, this would be the optimal set. This is how you should clump those areas together. Throw out those 11 regions we had before, do it like this, and you'd make things better. If we want 8 districts, they would be this. And these are straight out of her optimization problem, right? She found the districts that really maximize the supply-demand problem within the area. And she showed, out of all the combinations of things she ran, 4 districts, 5 districts, 6 districts, 7 districts, 8 districts, travel time max 3 hours, 4 hours, etc. You can see different constraints she fed this problem. And then what's on the y-axis here is that standard deviation of MELD score, how sick the liver patients are across those DSAs. Okay, so lower is better. Lower would mean you're more fair. Okay. This first dot local is what was being done. That was the law at the time. And so one thing I take away is anything is better than that. You know, pick your poison here. Anything is better. But she showed that some things are better than others, right? And national would be as best we could get, right? National says there are no constraints. We're going to send it from Maine to Hawaii. That sets the lower bound of the best we can do, right? And so you're trying to find things close to that, but not as far up as those ones that are happening up there, okay? So that was her suggestion of how to do this. All right. So has anybody heard of continuous distribution? I'm guessing you have, and Nick, maybe you've heard of this. Okay, so remember this comment back from 1998, what the government said? Assure that organs are allocated on the basis of medical need and that availability of organs will not be impeded by arbitrary geographic lines. When the OPTN, after those lawsuits, was charged with redoing this to get rid of arbitrary lines, Dr. Gentry's proposal with those districts was considered. The problem was, even with districts like that, 4 or 8, you still have lines, right? You still have a line. And so there's always going to be somebody right across that line who is sicker, right? There's always going to be that. And so we started putting our heads around this problem when these lawsuits came out, and we published this paper. This is our team at Hennepin here. Organ distribution without geographic boundaries, a possible framework for organ allocation. We hadn't used the term continuous distribution yet, but that is what it's called today. Okay, so we basically said, look, this is a pretty simple problem, right? You're going to come up with a medical priority score, which is we need to measure how sick people are. Right? That's going to be our first ordering of the line. And then I called it a geographic feasibility score. It's not always feasible to ship something from Maine to Hawaii, so we need to define that somehow. What should the shape of the penalty look like? And then you can add those together in some fashion to come up with the allocation priority. That allocation priority is how we're going to sort the list. Okay? And so we said it boils down to really those two things. How sick is somebody and how easy can we get the organ to them? If you do a system like that, there are no lines. The system will not stop at a state border just because there's a state border there. So that medical priority score, we already have these. Each organ actually has some definition of how sick people are. So we can already do that. We can already order patients. We would need to define this because it's not, we can't magically beam organs from one place to another. So we need to define this feasibility function. And then you just add them up and you get this. And I think this is what sold it to the committees. We conceptualized it as a hill, okay? So here's your donor. And we said, this is how far away each person on the wait list is from that donor. You can define that. We have co-distance flies from every donor hospital in the country to every transplant center. And you can do something more nuanced, flight times, drive times. We have all those APIs that can do that. But the basic concept is you have a penalty function, which we talked to the policymakers and said, just consider that to be the slope of a hill. Right? That's your distance penalty. And then for each person on the wait list, they're going to be somewhere on this line based on where they are, how far away. And there's 90,000 people on the kidney list, right? So envision 90,000 people standing somewhere on this hill. And this is about the max distance in our system, Honolulu to Puerto Rico. Puerto Rico has a transplant program, okay? So 6,000 miles, okay? And then the flag that they each have is that medical, how sick they are, the medical score, okay? So sicker people have a taller flag. And so the way this works is essentially when you have a donor, you're going to look who's got the tallest flag across this. And so I'm going to skip candidate A, even though candidate B is farther away, I'm going to call candidate B first because they're sicker. And I've defined this penalty function such that I know I can get the organ to them and it's the right thing to do. Okay? And you can make that steeper or you can make it shallower. You can do lots of things with that. And I'll show you, lung allocation was kind of doing this already when this came to be. They had what they called concentric circles. So rather than DSAs or state lines, they were doing like a circle around the donor hospital. If nobody wanted it there, they do a bigger circle. If nobody there, a bigger circle, okay? And you can conceptualize that as this penalty function. It's just a stair, right? So circle 1, circle 2, circle 3, circle 4, so on. So they were already kind of doing this. But the problem is nobody's flag on any of, if there was a person standing here, their flag would never reach high enough to get into this circle, okay? It was still a line that couldn't be crossed. They were always going to offer it. Even if there was a less sick person here than there was here, this person would get it, okay? So we said, well, this is a start. You could just smooth that out. Instead of a stair function, just make it a line, make it a curve. You could do this in different shapes depending on characteristics of the donor. So these are what's called donation after circulatory death donors. Those typically can't travel as far. So if they can't travel as far, just make the penalty steeper. Right? If they can travel far, like our brain dead donors, that's the DVD, make the penalty less. And you could do things like have cliffs in the function if you wanted, of some kind, where you're basically saying we never want to ship it past 2,000 miles if it's a DCD donor, but a brain dead donor will go 3,000 miles. But if we do go past that, we still need a penalty function, right? So we were just demonstrating you can design these functions in a smart way. This is the policy that they first implemented for liver, and they're working on a new policy to eliminate even this now. So this is, they currently have a circle system in place. It's a complex one, but that's the function that works it. And I won't go through all those lines. We're working with that liver committee now to smooth this out. Okay. And lung was the first organs to do this. Lung went into effect in 2023. And they remember my idea was there's really two things. How sick are you and how easy is it to get the organ to? Okay. They conceptualized it a little more complexly. These are the things they said matter. So they defined scores and functions for all of these components, and you add them up, okay? But essentially, that's what this is, right? So they put out a policy establishing continuous distribution of lungs in 2023. And for each of these things, there is a function, a mathematical function, that defines the priority for those patients. And then you assign a weighting to that component of the score, and then you add all that up, and that's your ordering line. And that ordering line changes for every donor that pops up, because some of that's based on the donor. Won't go through the equations, but just so you can get a sense, this is the equations for lung travel efficiency and travel proximity. They define two different components of that. So they have mathematical equations that give you the points. This was their graphic that they put out, and remember my curves, they defined rating scales that were smooth curves for both. That one's linear, this one's a curve. Travel cost, and this is the proximity efficiency and things they defined in each of those buckets. Lots goes into this. This is actually the function that they put in for the travel efficiency cost scale. You can see that there's actually some activity early on in this curve up here, and then it just becomes linear after that. Okay, I'm going to zoom in on that area. This is what it looked like. And they did that because organs early on are likely driving. There's some boundary where the OPO is going to say, oh, it's only 50 miles away, we're just going to drive it by ambulance or something. But then there's some point where that shifts to air travel. Okay? They're going to put it on an airplane. And that, of course, has cost implications, it has time implications. And once you get in on a plane, you know, it's going to fly 100 miles or 300 miles. That's a matter of maybe a half an hour. It doesn't really matter. So you can shape the penalty different for air travel. These are the survival formulas. These are the acuity scores that are actually in place. These are the formulas that judge how sick the liver candidates are. Okay, so that's part of that component. And then you add all that up, and then this is kind of the idea of what it looks like. And I won't go through all the equations, but they sort of walk you through it. And in their example, this person would get a score of 52.582. Everybody on the list gets a score. Put them in order, and that's the order they go down to offer them. Pretty elegant. So what happened? So this is an application from our website where we're monitoring this. So this is when the policy went into effect. And what we're trending over time here is a daily look-back rolling average of how far the organs traveled to those patients. Okay. So this was indeed supposed to more broadly share lungs, and it did. Okay. We went from like 200 nautical miles median distance up to like 400, 500 nautical miles that these things are traveling. So it did work to get the lungs offered out to patients farther. And I love this metric. What we're doing here is a 90-day look back on every day for how many transplants are done versus how many people die. Okay, so higher is better. Okay, so immediately when this policy was implemented, there was this huge jump in the number of transplants done relative to people that died. And that told me that there was this pent-up demand of sick patients that weren't getting offers based on where they were. The system went into place when we quickly got offers out to those patients, and they got transplanted, then it kind of leveled off. We made a modification in about a year later to how the ADR function is, the blood type scoring function was handled, because there were some inequities that we inadvertently introduced for blood type O patients. So that change modification was to try to correct that. And again, there was this bolus of transplants done relative to people dying, but it has continued to climb. So we're excited about that. We think that it is a fairer system, demonstrably, to get the organs where they need to be within a feasibility constraint. This is the waitlist mortality rate. You can see it's the kind of the inverse. This is the rate at which people are dying on the list. So right after the policies were implemented, we saw jumps, but it has continued to decline. All right, so here's another paper that was published in Informs, and this is a team that we work fairly closely with at MIT that's been greatly involved in the development of these policies. So Dr. Papalaksa, all right, I won't say it. But Dimitris Bertsmas is the head of the division there at MIT that's working on this. And Nicholas Trikakis, we work closely with this team. So they've published on how to do this well, and the reason I wanted to highlight their work is they have now spun up a website called transplants.mit.edu, and they have created a policy explorer tool for the creation of continuous distribution policies for organs. Okay. The reason I think it's really cool is because imagine these equations. There's so many factors that go into these, so many ways you can design the scores and the functions. How do you pick? Right? It's a really complex systems engineering problem, right? And so the MIT people are smarter than me, and they figured out a way to do this. So they have, this is a screenshot from the tool that I just took 2 weeks ago. And essentially you can go in, they have a kidney one at the top, you see K designer, and then PKP, that's pancreas, and then L is liver. And you can create policies, and these things are the weightings, like if you want to weight them, so somewhere 0 to 100, you can literally click on these and pull weights up and down, and the tool will then rejigger the outcomes of those policies so you can compare. They have other functions where they've created like the efficiency horizon or the trade-off curves. There's always a trade-off. If you're going to move one thing up, something else is going to give, right? So there's always a trade-off. So it's a really neat tool though, and you can design your own policies and try them out. It's pretty elegant. So take a look at that, play with it today if you get some, not in your class, but after class. All right. That's my last thing I just want to mention, which is a total shift in topic. But another way that systems engineering has influenced particularly kidney transplantation is what's called paired donation. Just have a few slides to show you about this. Again, our friends Summer Gentry here, operations researcher, and her husband, she's married to ISyE, who's a transplant surgeon. So you get a systems engineer married to a transplant surgeon, this is what happens. Okay. They have a 30-minute YouTube video, by the way, on how this works that was professionally produced. So if you get a chance, look them up. It's a great video. But they published this, how do we optimize the use of live donor organs? And the problem, this was her paper, the Kidney Paired Donation Fundamentals and Expansions. This was published American Journal of Kidney Diseases, where we were trying to teach the community how to do this. And essentially this works that, let's say you need a kidney and your spouse, for example, wants to give you theirs, but they're not a match for you. The way these work is you can find another pair that's in a similar situation, and their spouse could give to me, and my spouse could give to their loved one, and you swap. Okay, that's the problem. Like, how do we find those exchanges and make this work? Okay, and so that's what these diagrams are showing. D1 and D2. Let's look at just this big one here. That's the simplest problem, right? Where you just swap them. Donor 1 gives to recipient 2. Donor 2 gives to recipient 1. 2 people get transplanted. Everybody's happy. Okay. It of course can get more complex. This is the really neat example where you have what we call a non-directed donor. You could walk over to the University of Minnesota Hospital and say, I would love to be considered to donate a kidney to anyone who needs it. That's what we call a non-directed donor. You don't have a recipient in mind. That can fire off these what we call chains. Okay, and so that non-directed donor, they find somebody, they had a living donor that wanted to give to them but couldn't, so that person gives to that person, then you get on the list, and then when you run out of options, the last person gives to the wait list. And these are still being done today. They're often 12 or 13 chains long. So one person walks into a hospital and wants to donate a kidney, and it'll fire off 13 transplants, just like that. But how do you solve this problem? Right? This gets complex really fast. And so they visualized it as a graph theory problem. Anybody taking graph theory? So yeah. So each one of these nodes represents a donor-recipient pair that can't give to each other. And you put them in a circle and you ask the question, who can give to who? And you're trying to maximize how many edges we find. Edges are the lines that connect people, because you can do it probably in many different ways. But it's a linear optimization problem, right? How do you optimize the number of edges we find in that graph? Okay. So that's, here's an example on the right of the best one we can find of that string of lines. Okay. So it's another neat application, I think, of systems engineering that has really impacted our field. All right, I just leave with a call. supportive.